See the big sphenoid, what I could see this wall. See where the rostrum is or where the intersinus septum is. What do you see?
Yes.
So this was wide open. This was the supraorbital recess. And I am, see this is supraorbital recess now coming anteriorly. And this is frontal sinus.
Yes, sir.
So this was all about this case.
Sir, even the maxillary sinus is also small, sir.
What?
Maxillary
Hello?
sinus is also small now, sir. Right.
Not very big, reasonably good. See this? Not very big. Almost similar to the opposite side.
So these maxillary sinus, the floor is reaching a bit below the level of the palate. And we have done a type 2 MMA. So will there be a difficulty in the postoperative drainage?
Not really. Still it will drain towards the area we widened, ostium. Still it will drain there. It is not the gravitational drainage which is important. दिखा ना? दिखा. और उधर
उनकी सीढ़ी तैयार है आप.
हेलो अभी नेक्स्ट वो लेना वो लास्ट वो वाला ऊपर हाँ आज तो यही होगा. Hello.
Yes, sir.
So this was all about allergic fungal rhinosinusitis, the kind of pathology it is. It requires extensive, approach to remove all fungal and mucin material and give wide openings, hydrodebrider to rinse any, fungal particles left over the mucosa, like that. What my point?
Right, sir.
And that is how we could clear this. Now we have a good avenue. We could see with a 0 degree. We will train patient. I will show you tomorrow in the presentation how we train patient to, allow the secretion to go up. So this will go everywhere. That is classical a patient. Okay. Any questions regarding this, please? Can our patient go for next? Hello.
Hello. Sir, how many ampules of adrenaline you used in this case?
Depending upon 8, 10, 15, depending upon how much you use. But the concentration matters.
The fluid you have used is it hot saline or normal?
No, sir. See, hot saline concept is important for the areas. It is not important for here. Hot saline is important into areas of the skull base where you see the trabecular bone with a lot of venous channel into it, which bleed a lot. And there, hot saline is important in, initiating the coagulation cascade. In the sinonasal area, we rarely, promote the hot saline because it can be detrimental to the mucociliary activity. And it is not required in the sinonasal region. So, never that way. Hot saline is important in skull base, not in the sinonasal region.
Hello.
Hello.
Sir, I have a question. For a sphenoid sinus as small as this one, would a medial approach be safer to open the sphenoid sinus?
This was a median approach only, but the intersinus septum was far laterally shifted,
Yes, sir.
leaving this sphenoid a small one. So you have to follow the septum and then go behind the In the next case, I will tell you the guide is the septum. Always follow the septum and then, glide into the sphenoid sinus. To enter into the sphenoid, always go gliding along the septum. That is the safest way. Now, coming to this case, the next one, do we go ahead?
Sir, one question, sir. Sir,
Please.
post-operative in case of AFRS, should we start, sir, voriconazole or intraconazole?
Not. We have already discussed in the morning. These patients do not require antifungals. These are classically non-invasive fungus. Antifungal is required in invasive fungus, not in these.
Okay,
So
sir.
there is no question regarding the use of the antifungal in these patients. No way. Not needed at all.
So post-operative, what should be management, sir, for medical management?
Irrigation, douching after 2-3 days, oral
Okay,
steroids for couple of days,
okay,
and then periodical, cleaning, debridement, cleaning the crusting and all that to improve the steroid effect on the mucosa.
okay,
Our
sir.
steroid is basically, this douching is aimed at directing the steroid at the mucosal surface. So the mucosa revert back to normal.
Okay, sir.
Sir, the CT sections that you are demonstrating, in all
Mhm.
these, the section thickness is 0.625 millimeter. We are also asking the patient to get 0.625 millimeter. But sir, I always had a question. I don't know why the specific 0.625, why not 0.6, why not 0.5, why not 0.4?
It is somewhere between 0.5, 0.75. See, the idea is you don't miss any important structure.
Right,
More the finer section, the picture will be less, clear. Secondly, with 0.625, you don't miss any structure. The most important structure is the enteroethmoidal artery, which is roughly 0.8 to 0.9 millimeter in thickness.
Okay, sir.
If suppose I am jumping by 1 millimeter, I can entirely miss the artery. So these sections, 0.5 millimeter, obviously good, but that is not going to add any advantage. So this is somewhere in between
Okay.
that you don't miss any structure. Simple reason.
Right, sir.
Now coming on to the next one, change karna. Can you make out any diagnosis? Patient has polyps with this CT scan?
CCAD?
Yes. This class